Good morning, everybody. We'll get started. This morning, I'm very pleased to welcome Dr. Robert Miller from the University of Calgary. He's an associate professor at the University of Calgary. He's the medical director of nuclear cardiology and cardiac CT. He did his he did his training in Calgary and then did two fellowships in the US, one in heart failure at Stanford and one in advanced cardiac imaging at Cedars-Sinai. So his clinical work includes all aspects of nuclear cardiology and CT and also advanced heart failure service and cardiac function clinic. And his research interests include advanced imaging in patients with cardiomyopathy as well as clinical translation of artificial intelligence. And he's only been on staff for 5 years, but has already got some very impressive achievements, over 150 publications, and also two interesting awards. In 2024, he won the SNMMI Ones to Watch, awarded to early career researcher who's a rising star in nuclear medicine. And also, he won the top 40 under 40 in the Avenue magazine. Not sure what the Avenue magazine, it might just be your church magazine, but it's still it's still impressive.
Yeah, thanks for the introduction. And as mentioned, I do a lot of work in AI and nuclear cardiology, so I thought I'd just put together a talk that's AI in nuclear cardiology. I do have some conflicts. They're not necessarily relevant. The only one that's indirectly relevant is the Alberta Innovates grant, which is for unrelated AI work that I do. So in terms of just general outline for today, I thought it would be nice to talk about just some basic terminology and basics of AI, and then we'll talk about image reconstruction, segmentation tasks, and then disease diagnosis and risk prediction. So just starting off the bat, anytime we talk about AI, really we're just talking about any algorithm that can do something that we normally think of human intelligence as being able to do. So image recognition, language recognition, things like that. When we talk about machine learning, a lot of this comes down to like a tree-based model. So if you've ever done one of those online quizzes where you answer like 10 questions and then it tells you your favorite movie, that's a lot how a lot of the machine learning works. It's like a tree-based algorithm. Deep learning just talks about like a multi-layered learning approach. So for machine learning, you can ask it a simple question like, do they have coronary disease or not? And it just works down this tree to try to figure out the answer for you. So lots of benefits of machine learning. It can integrate a lot of information very quickly. The downside of that is you have to make sure you actually give it good data. So if you're leaking outcomes or variables related to the outcome, it will just use that one variable to predict the outcome. And then the other thing is you have to completely separate training and testing data. And a lot of machine learning and AI work sort of falls apart when you look at just the external testing data. It doesn't have any preconceptions about the variable importance. Maybe that's good. Or maybe you're stuck holding the bag trying to figure out like why Hep B surface antigen is important in predicting post-transplant survival. So you can have some difficulty reconciling the findings. Interpretability becomes a big consideration. Luckily, there's lots of methods for interpretability for especially machine learning based approaches now. And then if you're a real stats person, it's cool because it handles interactions and nonlinearity without you having to do any extra tuning. So in terms of just doing things from a statistical perspective, it just simplifies things. So again, for deep learning, it's this multi-layer learning approach. And then depending on how you structure that learning network, you can achieve different tasks. So frequently, like convolutional neural networks are used for like a classification task. Something that's used a lot in imaging are these convolutional autoencoders and UNets. So the idea here is you have sort of a collapsing matrix in the middle, and that forces the model to identify areas of the image that are important for whatever task. So this is used a lot for like image denoising. So if you take a spec study that's quite noisy, you feed it through this network. In those inner layers, it's forced to pick out the important parts of the spec image and then carry those forward. The UNet is just differentiated from an autoencoder because it has these skip connections that let it drag details from early layers to late layers. So deep learning has a lot of benefits as well. Firstly, you can just feed it images, whereas machine learning really works best with tabular data. It identifies some latent image features, so it might identify things that we don't think is necessarily clinically important, but it actually ends up being important. And then again, it has no preconceptions about what is important for the task. So here, explainability becomes a big issue as well. So this is just a study trying to predict COVID pneumonia. So what it's using here is gradient class activation mapping to highlight areas of the image that are important to the prediction. And what you can see is it's highlighting everything outside of the lung as important. So what it was using here, it was the radiology tags from one hospital that had a higher proportion of COVID. And then it was identifying the patient position. So if they were like a AP film, and supine, it was saying, well, this person has COVID. It's because they're in the ICU. It has nothing to do with the lungs. So especially for deep learning, it's important that there's some interpretability so you can make sure it's actually doing the task the way you think it should be doing it. So I think nuclear cardiology is like the perfect test case for AI. And that's because we have like predefined steps along a patient's journey. So we start with patient selection, we do image acquisition, image reconstruction, image segmentation, and then at the end of the day, we do like disease diagnosis and risk prediction. And the cool thing is you can apply AI at any part of this. So I think that's why it's a good example, but realistically, you could think of anything we do in medicine the same way. So when we get a transplant referral, we start with the patient, we start with the workup, you end up with some sort of risk prediction and then outcome prediction post. And really AI could be integrated that way with anything we do. So we'll start with image reconstruction. Mostly because this is actually something that a lot of us don't know what's happening in the background, so nobody cares if AI is doing it or if it's like conventional software. So actually, this is where AI is the closest or best integrated into clinical work. So there's actually some cameras that have AI already built in doing the algorithm. We just don't realize it. And realistically, everybody except Glenn probably wouldn't know, but Glenn would tell us. So this is one study that I just thought was particularly well done. So the cool thing with nuclear is you can collect all the data as like a list mode, and then you can separate out the counts and simulate low dose acquisitions without having to repeat this. So that's something that's not as easy to do with CT, and again, not as easy to do with MRI, but possible. So this is a study where they simulated half dose, quarter dose, and 1/8 dose acquisitions, and then used either a standard reconstruction or an AI-based reconstruction. And what you can see here is standard dose images are on the top row, and then as you go down, it's decreasing image counts. So if you look at the 1/8 image, as I skip past it, if you look at the 1/8 dose images, they're quite noisy. Perfusion defects are quite a bit larger. A lot of that has to do with attenuation. And as you go through the predicted outputs, which are the bottom 3 rows, you can see that they become more and more like the full dose images. And you can do the same thing from a quantitative perspective and just say like how similar are the images, and you can see the predicted images end up more similar to the standard dose images once you apply this AI-based reconstruction. So another task is attenuation correction. So for the fellows that have rotated through nuclear, you know, like attenuation defects are sort of the bane of most fellows because you're really trying to figure out what's real and what's not. So we can use CT-based attenuation correction to adjust for this, but you can also use deep learning to do that. So this was a GAN architecture, and then the generator is a UNet. So the general idea with a GAN is that you have 2 models that are training in parallel and sort of competing with each other. So the generator here is trying to create synthetic attenuation images. And then there's a discriminator that's saying, well, this is real, this is fake. And then you train them in parallel until the generator can totally fool the discriminator. And then you say you're done. So this architecture just ends up with higher quality or more similar images than if you just trying to UNet by itself. This is just some case examples from that study. So on the left, you can see non-attenuation corrected images. In the middle is the CT-based attenuation correction. And on the right is the deep learning-based attenuation correction. So on the NC images, what you can see is that there's A small, mild defect in the basal inferior wall, which is pretty typical for the location of a diaphragmatic artifact, and distribution looks like it. You can see with CT-based attenuation correction, that artifact is gone. And similarly, with the deep learning-based attenuation correction, you can see that that artifact is gone. We went one step further and applied what we call change analysis. So the idea with change analysis is you're directly comparing the voxels within this polar map to say how many counts are there and what's the difference. So here what you can see is that if AC versus NC, there's a correction in the inferior wall, as we know. There's no significant difference between the AC and the deep AC images though. One thing about synthetic attenuation correction is sometimes they just make all the polar maps normal. So what you want to make sure is that it doesn't get rid of all the defects that are there. So what you see here is that on the NC images, there's moderate to severe perfusion defect in the lateral wall, consistent with like a circ territory defect. That defect is still present on the CT-based AC images, and then it ends up still being present on the deep learning-based attenuation correction. And here what you again see is that there's some correction of the inferior wall and inferolateral segments on CT-based AC versus NC, but no difference between AC and deep AC. Just one more example. So if you look through all the cases that we put together here, what you can see is that there's significant improvement in terms of positive change, meaning that these corrections, when you look at AC versus deep AC, end up being much less than when you look at AC versus NC. We went on to look at prediction performance. So this was an external testing population, and we just showed that quantitative perfusion with total perfusion deficit with deep AC had similar prediction performance as the actual CT-based AC. So all of this was done with two specific solid-state SPECT-CT scanners. So in general, in the US, solid-state cameras make up like less than 10% of the market. Hybrid scanners make up 15% of the market. So there's 85% of the market that's like standard and or angular cameras without CT-based attenuation. So more recently, we've been seeing if you can apply the same algorithm to cameras that don't have CT-based AC, because realistically, that's where this would be helpful. So this is just a case example from that study. So here you see deep learning based AC on the top, and then NC is the second row, and then it alternates all the way down. On the NC images, you can see that there's, again, a moderate intensity defect in the anterior wall. That's more basal to mid, sparing the apex, sort of consistent with what we would see with the breast attenuation artifact. And with deep learning, that artifact's much less obvious. So this patient had no coronary disease. So these are all studies from the Fleur-Paradise clinical trial. So moving on to segmentation. I put this image up here just because it's nice to look at. So this is work from David Ouyang's group, who's down at Cedars. And Echo's done a lot of work in segmentation, but there's lots of segmentation tasks in nuclear cardiology as well. In terms of like myocardial segmentations, software is very good at this because it's been working at it for a long time. But there's lots of different segmentation tasks to do from the hybrid CTs. So one thing that we all do, I think visually, and very few people do quantitatively, is look at the coronary calcium. So we say, well, how much calcium is it? How many arteries is it impacting? And we put out this study just showing that even if you just put them in the grades of like absent, equivocal, present, extensive, that can predict MACE risk, and it's incremental to all the perfusion imaging variables that you can look at. It's possible to quantify CTAC. The images are quite a bit noisier because they're acquired with lower radiation doses. But this was work that we used deep learning to try to segment out the coronary calcium for us. So this is a convolutional long short-term memory model. So the general idea here is deep learning is behaving the same way as human readers do. So typically, if you look at a slice, you don't know what something is, you start looking up and down. So here what you do is you feed the model the single slice that it's looking at, as well as the slices above and below, so that it gets context for the calcium. So here it does two tests. First, it segments out the heart mass, so it's just saying this is where the heart is. And then inside the heart mass, it uses like density and location to separate coronary calcium from non-coronary calcium. So again, here we separated out a training population and an external testing population, and just validated all of it from two perspectives. So the first perspective was, how do deep learning calcium scores compare to expert calcium scores? So if you added up all the cases, there were just about 9,000 cases, and one person did manually segment 9,000 cases for coronary calcium. So you can imagine like how much their eyes hurt after looking at these cases and doing that. What you can see here is that the deep learning calcium scores had pretty good agreement with the expert calcium scores. The trouble is there's no real ground truth, because you could say, well, maybe the expert's wrong. So then we went on to look at prediction for outcomes. So here, what you can see on the left is incidence of MACE by deep learning calcium scores. On the right is incidence of MACE by expert calcium scores. And you can see that those Kaplan-Meier curves are very similar, in spite of some differences in terms of classification. And if you look at the unadjusted hazard ratios, you can see that they end up being very similar. So unadjusted hazard ratio for calcium score over 400 was 5.9 versus 6.3. The biggest difference wasn't in patient reclassification, which was identical between deep learning calcium scores and expert calcium scores. It's in the time. So if you're doing deep learning calcium scores, it's less than a second. If you're doing the expert reader score and you're scoring these 9,000 studies, about 5 minutes per case. So I personally don't care who's scoring the calcium, as long as it's done. And ideally, it's not me. So that's like a very easy task to give to deep learning. We did go on to compare like scores between ECG gated calcium scans and the low dose calcium scans. And again, there's no real like gold standard here, but outcome prediction we use as the gold standard. And you can see that it ends up working about the same with these low dose CTAC scans as with ECG gated scans. So we started from there and then we slowly worked outwards. So this is a study that looked at a deep learning based segmentation for epicardial adipose tissue. So that's like the fat tissue next to the heart. So when you look at ECG gated scans, this is actually an area that's pretty easy to define. The trouble is when you start talking about CTACs, the heart's moving, there's a lot of motion, there's partial volume effects, but we still wanted to see, well, can we get the same information from CTACs? So this was a study where we did both internal and external training and testing. So the internal site was 4,000 patients. We took out 500 for the initial model training and then used the other 3,500 for internal testing. And we used the same deep learning setup as for the calcium model. So I said before that we started by selecting out the heart mask. So here we just used the heart mask that we had already created. And then within that heart mask, we segmented based on attenuation. So just like the calcium study, unfortunately, one person had to go through each of these slices and segment out the epicardial adipose tissue. So we started by comparing the deep learning epicardial adipose tissue segmentations to expert segmentations, and you can see they're very close. And realistically, the expert segmentations take about 10 minutes. So nobody's going to do this on a regular basis. Sorry, if you're fast, they take 10 minutes, I should say. So these are just two case examples. So on the top, you can see it's a patient with a pretty high calcium score, around 1,000, 51-year-old male with EAT volume that is quite high and EAT attenuation that is also high. And that patient ended up having an MI at 200 days. On the bottom, you can see a patient, similar calcium score, but not as much EAT. And the EAT density is lower, which is associated with lower risk, and the patient had no events during follow-up. So if you look just at perfusion and EAT volume, you can see that they're incremental. So low EAT volume, normal perfusion is the lowest risk patients. Abnormal EAT volume, abnormal perfusion, highest risk. And if you have either discordance, they were about the same outcome. We went on to do more adjusted analyses, and I'm just going to blow this up because it's like impossible to see with the screen. But both EAT density and EAT volume were independent predictors of outcomes in this study, both in the internal and external testing populations. So since then, we've kept just going further out. This is a study that just recently got accepted in Lancet Digital Health. Here we took a cohort of 4 sites with SPECT-CT MPI, and we used again those CT attenuation correction scans and applied a segmentation tool. So the first thing we started by doing was restricting the volume just to T5 to T11. And then within that volume, we established where the intrathoracic and extrathoracic cavities were. And then once you had that, we could identify tissues based on density. So what this does is it tells you how much muscle there is, how much fat there is, and where the fat is. So this is just blowing that up a little bit. So why did we pick T5 to T11? Well, if you look across these 4 sites, all of the scan ranges are different. So ideally what you have is a volumetric measurement that's similar across every site. So what we did was we picked T5 to T11 because it was the area that was consistently present. And then, like I said, within that, we separated out the tissues based on relationship to the thoracic cavity and density. So if your fat density outside of the thoracic cavity is subcutaneous fat, muscle has separate density, so you can extract that. Any fat that's not connected to the skin, we labeled as intermuscular fat. And then if your fat within the intrathoracic cavity is either EAT or visceral adipose tissue, depending on where you are. So it generates really cool images because you can say, well, if you take the CT scan, this is actually your body tissue composition within your chest. This is just another example of what those segmentations can look like. So there's some really unexciting findings in the study, and there's some interesting things. So the things that make sense to all of us is if you have more skeletal muscle, you do better. If you have more visceral fat or epicardial fat, you do worse. The interesting thing is if you have more subcutaneous fat, you do better. So maybe it's a way to sort of unravel the obesity paradox, because it's not how much fat you have, it's where you put it. We also went on to look at densities, and there's independent prognostic value from all the densities. So more dense skeletal muscle is associated with lower risk. More dense adipose tissue, regardless of where it is associated with increased risk. And all of this was independent of all the perfusion imaging findings, medical history, age, and sex. We have similar data in PET, where we can also correct for MFR. It's going to be presented at ACC, and it's under embargo at EHJ. So a lot of that was based on an NNU net, which is like what was created for Total Segmentator. Total Segmentator had a really interesting like training and testing pathway. So it started off by a single person just annotating a full CT, saying like, this is the vertebra, this is the liver, this is the spleen. And then they trained a very early version of the model, and then pre-segmented CTs. And then again, a person went through and corrected all the segmentations, and then they did this iteratively. So it saved a ton of time in terms of the manual segmentation task. And since then, people have used this for a lot of different things. The cool thing about the model is it was trained both on contrast enhanced studies as well as non-contrast studies. And then what you can do is you can apply it to a non-contrast scan. So CTACs are non-contrast CTs are non-gated, but it was trained on enough contrast enhanced gated scans that you can estimate cardiac chamber volumes from the CTACs. So what we did here is we applied that to SPECT-CT studies. And just looking at the segmentations, 2 case examples here. So what you can see is that it's segmenting out the right atrium, the left ventricle cavity, and the LV myocardium, as well as the right ventricle. So this is interesting for a couple of reasons. One, you can't measure atrial volumes from nuclear perfusion, like there's not enough myocardium there to find it. And 2, If perfusion is abnormal, that's actually a difficult segmentation task for nuclear because it's using the counts to find the wall. So if you have a huge infarct, you'll see that usually the volumes are wrong, the ejection fraction's wrong. So that's maybe where CT could help you get the correct volumes. So what you see here is just two case examples of where they're a little bit discordant. The bottom case is related to this large perfusion defect in the inferior wall. So the first thing we did as part of this study is did segmentations for contrast enhanced studies and compared that to non-contrast ungated studies. And what you can see here is that there's actually really good correlation between left atrium between the two image sets. There's more discordance with the left ventricle cavity, and that has a lot to do with when you do a CTAC, you don't know what phase of the cardiac cycle you're getting, so it's difficult to actually estimate the volume. And then right atrium and right ventricle ended up agreeing pretty well. If you look at just quartiles of these volumes, that you can see that they're increased risk as you go up with increased volume, as we'd expect. So the interesting thing about this study is if you look and adjust for all the perfusion findings, like coronary calcium, age, sex, and demographics, left atrial volume was highly predictive, independent of all the perfusion findings. The left ventricle tended to be less important because you already capture a lot of that information with the perfusion. So it worked out well that left atrium was the one that was most reliable or most consistent with the ECG gated studies. We have also tried to extend this to PET-CT cohort. So again, same thing, we're using a modified NNU-net to segment out the cardiac chamber volumes. And here you can see that each of the cardiac chambers was independently predictive, more so for heart failure, but also for death or MI. And you could just add up the number of abnormal chambers. So here you can see patients with all normal chambers, significantly lower risk of heart failure hospitalization. If you have 3 or 4 abnormal chamber volumes, your risk was 7-fold higher. So again, all of this information is bundled into the CT scan. We're just not using it. And realistically, I think most of us use the coronary calcium routinely as like a visual check, but nobody's measuring skeletal muscle. Nobody's estimating left atrial volumes. So potentially it's additional information that could be given to the physician to say, hey, this person needs an echo. Hey, this person should be referred to a heart function clinic. Or in the case of sarcopenia, hey, this person needs cardiac rehab. Nuclear isn't all about perfusion, even though it's like 90 to 95% of what we do. So this is just a pyrophosphate case. Pyrophosphate imaging is highly accurate for diagnosing amyloid. And the field has really started to focus on SPECT and SPECT-CT imaging. And that's because really the question is like, is the uptake in the myocardium or is the uptake in the blood pool? It's sometimes difficult to tell from a 2D image, but it's really easy to tell from a 3D image. So in terms of diagnosis, this has become gold standard and everybody switched to non-invasive diagnosis of ATTR. But then the question is, well, what other information can you get from those pyrophosphate scans? So we did a study where we were trying to quantify the activity within the myocardium. So here, the segmentation was based off of a target that was placed either in the left ventricle or the left atrium, and that was used to determine the background activity. And then we put a region of interest over the myocardium and said, well, everything above background in the myocardium is abnormal. And then you can get volume of involvement and also cardiac pyrophosphate activity, which is a combination of both volume and severity of uptake. So we showed that it's highly accurate for diagnosis, but it was also predictive of outcomes. Unfortunately, like, again, nobody really wants to draw these circles. So I was the poor sucker who was drawing the circles for the last study. And I said, I really don't want to draw any more circles. So isn't there a way somebody could do this for me? So here we use the same idea of segmenting out the chambers to get somebody else to do the circles for me. So here what we do is we do the chamber segmentations from the CTACs. And then within those segmentations, you can identify different target regions. So we started with a full-size left atrium, a shrunk left atrium, and then just random samples within the left atrium. And then if you co-register those images between the perfusion or the pyrophosphate imaging and the CTAC, then you can quantify everything that you would have quantified just manually. So this is how that looks. So again, you can see the chamber segmentations on panel B. In panel D, you can see that we co-register the images. And then in panel E, you can see, well, we use the left atrium. Just realized my cursor is not always on the screen. You can use the left atrium as the background. So again, that gives you a sense of like how much background activity there is. And then you use the LV myocardium as the target, and you can get all the same quantitative measures. So as you can see, like this is a positive case. The quantification is abnormal. This is a case that's negative, so all the uptakes in the blood pool. You can see that actually this LV segmentation nicely outlined where that blood pool was. So again, this was highly accurate for diagnosis, but that's not a difficult task. Like I think most of us can look at a SPECT CT pyrophosphate case and decide within a couple seconds. So that's not necessarily something I need AI to do for me. But if you take the quantification, you can then predict risk. So what you can see here is we looked at many different quantification methods. They were all associated with an increased age-adjusted risk of cardiovascular death or heart failure hospitalization. So moving on, this is just for Dr. Burney. So you can do the same thing for sarcoid. Again, we did different regions for the background and then use the LV myocardium as the target. The RV myocardium is just a little bit thin, so it's harder to get a target there, but we're working on a method for that. And then here you can see like the co-registered images, and what you can see is you can get all the quantification that you might want for a sarcoid study: volume of involvement or inflammation, cardiometabolic activity, target to background ratio, SUV max, all without having to do the segmentations. And in comparison to like traditional software processing, sarcoid can be quite hard because the uptake is patchy, or if it's negative, there's no uptake. So that's difficult for most commercial softwares to quantify reliably. So this is a way that you can get reliable segmentations to get the quantification. Moving on to something that is maybe a little bit more exciting, is it's not just about drawing circles. So like I said, we always start with like, what's the right test for the right patient? So if you're going to select patients for stress-only perfusion imaging, you'd say, well, if I know it's going to be normal, then stress first makes sense. If I know it's going to be abnormal, then a stress first makes no sense. So this was a machine learning model that we used just pre-test features to decide who was going to have abnormal perfusion. And what you can see is it was actually highly accurate for identifying abnormal perfusion, and certainly outperformed all of the traditional scores that we might want to use both in internal and external testing. The other task you might want to offload to machine learning is, of the patients who undergo stress first, who doesn't need the rest scan? So the general idea here is if you have totally normal stress perfusion, you don't need the rest imaging because it's not going to add anything. So a lot of sites have a physician on standby reviewing these cases on the go to decide, well, who can go home, who needs the rest imaging. Again, this is a task that you could offload to machine learning so that you could be doing something else. Like you get paged, you have to go to a code, you have to deal with anaphylaxis, something. So this was a machine learning model that took all the clinical and demographic data plus the stress perfusion, and then it identified who's going to have coronary disease on their invasive angiography. And you can see it does this much better than either total perfusion deficit, which is quantitative perfusion, or expert reader interpretation. Or you could say, well, actually, I really just care who's going to have an event. So you can predict risk of MACE much more accurately than stress perfusion or physician diagnosis of perfusion. The trouble with this model is that it had a ton of variables. So you can imagine, like, if you can't extract all these variables, then some poor sucker is again stuck entering all the data so that the machine learning model can give you the prediction. So the follow-up study to this was to try to figure out, well, how much of that information do you actually need? So a lot of the stress perfusion stuff you can automatically export from any software, regardless of what you're using. So here we focused on just variables that you can't collect automatically. So here you can see just in terms of feature importance, as you go further down, things become less important. And then what we did is we started by building a model that had just the imaging features, and then we added individual non-imaging features until the prediction performance plateaus. And that sort of tells you exactly how many variables you actually need for the prediction. So instead of collecting 60 manual variables, you really only need 8 to 10 variables to get highly accurate predictions. Again, moving on to something that is even a little more exciting. So this was a deep learning model for perfusion interpretation. So here it's a deep learning model. The input is perfusion, motion, and thickening polar maps. And if you are stuck in nuclear long enough, you start to think about the world in polar maps just because it's like a 2D representation of everything that you're trying to see. So it's a really easy way to train a deep learning model because it's 2D representations of a 3D data set. And then in the final layer of the model, we feed in things you don't get from 2D imaging. So like volume, age, and sex. And then the cool thing about this model is it incorporated different methods for explainability. So we talked a little bit about gradient weighted class activation mapping before GradCam. So this incorporates GradCam, but gives different explainability tools. So the first is the attention map, which again just highlights the area of the polar map that's most important. It also gives you per vessel probability of coronary disease. And then at the bottom, it tries to just like score polar maps for you and say like, this is a segment you should be looking at. So in terms of cases, what you can see here is if you look at the perfusion on the left, there's a relatively small mild perfusion defect in the distal anterior wall and apex. This is the same area that's being highlighted by the deep learning model. And then it's highlighting those segments for you in case you can like localize the segments relative to the attention map. And then it says, well, there's 75% probability this is LAD disease. So again, this is integrating not just the perfusion, but also the motion and thickening. So like somebody might say, well, I think it's apical thinning. Here, the map is, or the model's looking at motion and thickening to differentiate that rather than just perfusion on its own. So in this study, there was tenfold repeated internal testing, and what you can see is that prediction performance for coronary disease was significantly higher than total perfusion deficit as well as reader diagnosis. There was also 3 sites held out for testing, and here it also outperformed in external testing. And just, I think case examples here are the most interesting thing. So what you can see here is that there's a partially reversible defect in the inferior wall, mild to moderate intensity, moderate volume. You see the same thing here on the polar map. And that's really consistent with like RCA ischemia. The interesting thing is if you look at the deep learning model prediction, it's saying, well, yeah, there's a high probability of RCA disease, but there's also something in the apex. So as we all know, like the most often missed abnormality on any imaging is the second abnormality. Like we all focus on the big one that we see, but you sometimes miss the second abnormality that's more subtle. So maybe a way that you could highlight that. This is a case where there's a partially reversible defect in the septum, mostly in the anteroseptal wall, a little bit in the inferoseptal wall. But here the deep learning model says, well, there's no risk. So you can work backwards through the case and say, well, this person had a left bundle, maybe there's a left bundle branch block artifact, which that's what it ended up being, or else I wouldn't show you it. So following that, we asked the question, well, there's all these explainability parameters. How do physicians actually use this? Like, can you actually use this as a tool that you read better? So here what we did is 3 readers read 248 cases that we would read any nuclear study. So they got the clinical data, the stress data, and they had their perfusion scans. And they scored all the studies with some stress scores, some breast scores. And then they did the exact same thing with the deep learning predictions. And then we just compared accuracy for readers. So here it's blue is readers with deep learning compared to orange which is readers without deep learning. And in general, quantitative perfusion with stress total perfusion deficit is as accurate as readers, but more reproducible. So a couple interesting things here. First, the readers are very good because they're beating TPD, which is unusual. Second, you can look at each reader with deep learning versus each reader without deep learning. So overall, the readers improve, but if you look per reader, some readers improve significantly, some readers improve a little bit. Everybody was at least numerically better. And then my wife does psychology. So like she loves this because it's a lot about psychology of how people use AI. So you can sort of look at how people are changing with AI and sort of label them. So this first person improves both for sensitivity and specificity. So I think of them as like the AI believer. They're sort of really using the AI predictions regardless of which direction. The second reader, there's no improvement in sensitivity, but there's good improvement in specificity. So this reader seems to be saying, well, I know when it's abnormal, but if it's normal or I'm on the fence, then maybe deep learning could push me. So they're using AI as a rule out and saying, well, if I think it's probably normal, AI says it's normal, I'll just call it normal. The third reader really doesn't improve much. So I call them the cautious skeptic. The other name for them is the person who almost ruined the study, because like if everybody read that way, it wouldn't have worked. And then if you look overall, you can see overall there's improvement in both sensitivity and specificity. Part of the trouble is like not many of us think about probability when we're interpreting perfusion. Usually we're trying to score a defect. So more recently, we worked on a way to translate the deep learning probabilities into traditional scores. So this is really interesting because you're trying to combine the knowledge that's inherent in how software processes perfusion with AI. So what we did is you start with just traditional quantitation, which is based on like the depth of a defect on a polar map. And then you take those polar maps and you incrementally adjust the scores per pixel until the deep learning scores are the same as the predicted probability based on like a per segment mapping system that we worked out. And then we compared accuracy for coronary artery disease. So here we were using actually the same external testing set from the initial deep learning model. So it was not used as part of the deep learning model. And this is an example of how that works. So here you can see standard quantitation on sort of the middle panel. I really should have brought a laser pointer. That would have been clever. And what you can see is it's scoring like anteroseptal segments. If you look at this perfusion abnormality, it's again this anteroseptal thing that's partially reversible. So this was another left bundle artifact. So it's a patient without coronary disease. So if you look at the deep learning prediction, it says, well, there's low risk of coronary disease. So what it does is it incrementally pushes down the per pixel value of the TPD until it matches what the deep learning says it should be. So it pushes all those scores down from like 2s and 1s to like a single 1, which is probably normal in most labs. So the really cool thing about this is like in theory, you're modifying the deep learning source. So there's no reason it should outperform the deep learning model by itself. But that isn't what we found. So CAD-DL is the deep learning model by itself. So AAC of 0.795. The stress TPD from deep learning actually outperformed that significantly. And it's probably that you're integrating like all this knowledge inherent in software quantitation that says, well, if it's a tiny defect, it really doesn't matter how severe it is. You can only score it so much. There's only 4s. So there's probably some benefit to integrating AI with traditional software approaches. Okay, moving to something totally different and trying to leave room for questions. So all the tasks I was talking about before was like really classification tasks, so it's all supervised learning. So if you think about Candy, it's like which of these candies is delicious is the question that I was asking deep learning before. So instead of doing that, you could say like, can you try to categorize these candies for me? So that's what unsupervised learning does. It looks at the structure inherent in the data rather than like a classification task. So you're not telling it what to find, it's just tell me something about the data. So here we took patients with normal perfusion on SPECT-CT and just applied an unsupervised clustering approach. So we split training and testing populations. So on the left, what you can see is that the optimal number of clusters that we found was 4. And there was good separation in the training population as well as in the external testing population, although with like a little bit of skew in patients in this artificial space that's created. So this wasn't developed to find risk, but risk sort of validates what you find. So these are the 4 clusters, just looking at the relative risk. And what you can see is that the risk between cluster 1 and cluster 4 is significantly different. This is always interesting from a clinical perspective, because then the question is, well, what are these actual phenotypes that you're finding? So the biggest split here was actually by exercise versus pharmacologic stress, which is something we've known about in nuclear for a long time. Like if you're able to walk long enough to exercise, then you're probably going to do better than the person who needs pharm stress. So that's, I think, pretty logical for all of us. And then it used a lot of these other factors like age and sex and perfusion findings to differentiate cluster 1 and 2 and cluster 3 and 4. And then the one thing that separates 1 and 2 from 3 and 4 is really just exercise stress here. So we applied that same clustering in an external population, again, saw this risk differential with very similar phenotypes. And again, it was mostly split by exercise versus pharmacologic stress. So last but not least, I thought I should at least talk about large language models. So if you just ask ChatGPT, as a cardiologist, how should I use large language models? This is what it says that you should do. And it has a rationale for all of these. And these are, I would take them as suggestions, but these are things that we could think about in the future. We always want to know, like, is it accurate? And oftentimes we say, well, if it can pass a board exam, it's at least as good as the person who can pass the board exam. So we did a study where we tested it on board prep questions for nuclear cardiology. So I'm a little bit biased, but I think like the nuclear cardiology exam is very easy. So like it should be easily passable. So here what you can see is performance for different large language models on these prep exams, which are very similar to the nuclear cardiology board exams. And it did okay. So if you look at overall accuracy, ChatGPT 4.0 hit 63% accuracy. The CBNC doesn't release what the passing score is, but we think it's around 60%. I think most people who read it who pass are like in the 90 to 95% range. So here ChatGPT or GPT 4.0 might just pass, so not quite there. But the cool thing is like these models are always evolving, and eventually like the knowledge level will be there. There's ways to give them context specific information. So more recently, we just fed them like textbook chapters from nuclear cardiology to prompt them before testing them. And then you see performance improve significantly, but still only to like the 70% range. So not really as good as physicians, even with that context specific training. So lots to try to get through. I left 10 minutes for questions. Any questions?
It's really super. Do we have online questions, Dr. Sadik, as well? Not yet. Okay, but you're monitoring them. So we'll start with Dr. Patterson.
I can repeat it if that works.
Yes. We've got a mic here.
That was very, very impressive. I have a question. So I dabble a little bit in AI, nowhere to the extent that you are. In MRI, we use something called radiomics, or I've been dabbling. And so that's looking at texture, sort of the intensity of pixels to get information about different types of activity going on within the tissue. So the work that you showed mainly asked the question, is this fat? Is this skeletal muscle? But can you actually go into the tissue and separate the different components? Like, is there water? Is there fat? Is there inflammation? Can you use sort of texture analysis with the CT data to look at that? And so some examples would be like the liver is a complex structure that has fat and water in it. Can you separate those out?
Yeah, and so it's a great question. Like radiomics is a cool field, I think, and it works really well with AI, because the trouble with radiomics is you're going to generate like 300 features for each thing that you look at, depending on like how detailed you do the radiomics analysis. So it's a really good question. So we've done some work on liver, because we were like thinking about this idea of like fatty liver you should be able to find on CT. And a lot of that is actually related to the texture rather than just the absolute pixel values. So we were able to find like a signal within the liver by itself, but it wasn't honestly all that super impressive. So that's something that we're working on getting published now. But even if you just take that full chest CT, you can look at everything within it. And we took just like first order radiomics and said, well, if you segment out all the organs, and you take first order radiomics, can you predict risk and then flag people? That combines a couple different things. So we categorized all the features under an organ system, and then we used information gain to say like what's the most important organ system in this prediction. So because you capture liver, lungs, skeletal muscle, bone, aorta. So this was led by Anna Marcinkiewicz, who's a Polish fellow working with Piotr Słomka, and she took our CTAC scans and segmented out all the organs using the NNUNet. And then you can use the radiomics to predict risk. But the cool thing is you can also flag the organ and say, well, this person's at increased risk. It was lung that was most important. And if you go through the cases, some of those had like pneumonias and cancers. Aorta tended to be high for a couple of patients that had like aneurysm that might have been flagged with this approach. So yeah, radiomics is super powerful tool. Certainly applies really well to CT imaging. Not quite as well to nuclear imaging, just because the images are a bit simpler.
Okay, very impressive presentation. Really a great body of work that you shared with us today. My question is more about as a program, how do you build the data sets that enable this? Because that you can do a lot of machine learning, but if you don't have the data, you can't really get anything of substance. So what's your approach to that?
Yeah, so I think it's a great question. It is really the biggest task for any program in AI is like getting good quality data. So my first thing is like I have a good network of collaborators, and a lot of them have done that work. So like Piotr Słomka has spent years and years and years to put these cases together where you have both the clinical data and the imaging. The good thing is once you get all this data together, all of a sudden you like have this huge body of work that you can generate from the data that you put together. In Calgary, we're working on ways to like collate data from different data sources. And James White is leading a lot of that work. But it really is a huge investment. Like once you create this data resource, especially if you can have it like totally de-identified and from like safe from a privacy and security pathway, all of a sudden you have like this gold mine of things that you can go in and look at, especially once you start combining imaging with all the clinical data. It really makes it a rich data set to work. So I think that's where I've had success is like these larger data sets that are curated over time. In terms of collecting data from multiple sources, it's always difficult, right? Because people have different data definitions. So if I try to get data from Boston, it's going to look different than data from Mayo Clinic is different from Calgary is different from Ottawa. So it's always a double-edged sword. The trouble is like right now you really need external data for anything that you're going to try to publish. So I think we're all in this world where we need to collaborate, but it's hard to get these collaborative data sets up and running.
Fantastic.
And as per Pascal, great body of work, everything from moving from drawing circles to cutting edge AI implementations. A couple of practical questions. You talked a little bit at the beginning about attenuation correction, and the deep learning was effective for inferior wall. We know that also SPECT overcorrects in the anterior wall, something that Len's explained to me half a dozen times that I've never really fully understood. How does AI perform in the anterior wall?
Yeah, so it's interesting, and it's a good question. The trouble is always like the ground truth. So like for that study, we were saying, well, CT-based attenuation correction is a ground truth. The trouble is we know CT-based attenuation correction isn't perfect. So just like the way this is trained is it's getting as good as, it should be as good as CT. I think like anecdotally, there's some cases where it doesn't correct as much. Interestingly, like in this work with the NC only data set, we're seeing like some defects are being brought out in the anterior wall just because it's like correcting relative perfusion defect in the inferior, which brings out the anterior to make it more apparent. So it's certainly not perfect and definitely needs validation in terms of how accurate it is. I think realistically, you end up using it the same way you use CT-based attenuation correction, where you don't necessarily think it's the truth, but it's an extra piece of information. Whereas you still might want to use like prone imaging and other ways to get around attenuation artifacts like motion. So I just see it as an extra piece of information.
Okay. I also kind of building on what Ian asked about the characterization. We talked a little bit about this last night. Is there thermogenic brown fat in the field of view? Can you distinguish that? Is that part of the subcutaneous fat? Any thoughts on that? And is there sex differences between men and women? You didn't really talk about that.
Yeah, and part of the trouble is like the nice figure I have is, so again, great question. The really nice figure I have for sex differences is like under embargo, or else I would have shown it. But yes, there are sex-based differences. There's also differences across different races and ethnicities. So like a lot of this needs like larger patient populations to get more concrete data across subgroups. In terms of differentiating like brown fat from non-brown fat, it's not something we've done, but in theory, you should be able to do it based on attenuation differences.
Question. We talked a little bit like this last night, Rob. You know, projecting 10 years into the future, I think AI will be reading ECGs and not EP docs. What do you think the life of a nuclear cardiologist is going to look like in 10 years' time?
Yeah, no, I think it's interesting. And again, a good question that usually comes up once we talk about AI for too long is like, when are we going to be ready to let AI do a lot of this stuff for us? I think segmentation tasks are easy to offload. So like if you're asking your echo text to segment out echo images and get your EF and your volumes, then like really nobody cares who does this as long as somebody looks at it and has some oversight there. I see nuclear cardiology a lot the same way. Like there's segmentation tasks and then there's diagnosis. And I think at the end of the day, patients still want a physician who's looking at this, even if they're not quite as good as AI by itself, because there's going to be areas where AI isn't perfect either. And physicians can pick up these defects. So again, like if you go back to the reader study, one of the readers like outperformed deep learning. So like there's knowledge that we have that deep learning doesn't have that we can integrate. And just the same way, like if you look at this deep learning perfusion scores, like there's knowledge in the software that it was able to get and integrate and improve. So I think there's always going to be a physician there who's overseeing and making sure it makes sense. But increasingly with AI support to make sure that the decisions are correct.
Yeah, being able to do more and faster and so on. Kind of building on that, you showed a study where you were predicting the likelihood of positive results. So then that kind of begs the question, building on that, why do the test at all? If you can actually predict it that well, why do the test at all?
Yeah, and I think you usually want a test because like the person in front of you, you're seeing a patient who's having chest pain, you want to be able to tell them like, why do you have chest pain? So I don't think many patients are going to be happy to hear, well, I ran it through a prediction model, your perfusion's abnormal. Or your perfusion's normal, we don't have to do anything. They'd want to know what their perfusion is. We didn't get into this, but like right now, a lot of what we're doing with nuclear isn't about like, is it normal or abnormal? The question is like, how bad is it? Like how much ischemia, where is the ischemia, what needs to be fixed? So you're never going to get that with just this approach. But it does raise interesting questions about if you know somebody's perfusion will be normal, do you still want a SPECT? Do you want an exercise SPECT or do you want a PET so you can get flow, or do you want a CT so you can get plaque volumes? So, I mean, we're lucky that we have so many options to choose from, but that's always the trouble is like there's options. So what should you choose in this context?